Thanks, Bhagyashree, for kind introduction. Thank you, ACTA. Thank you, Scientific Committee. Thank you, Sandeep Mutha, and thank you, Dr. Vinayak Desirkar, for the opportunity. So basically, I'm going to talk about the clinical ultrasound. So what is the clinical ultrasound? It's essentially the use of the ultrasound in the clinical situations. So what I'm going to do in for about next 16-17 minutes, I'm going to talk about the utility of the ultrasound and show you the various possible evidence and make you sure that you are going to use this ultrasound in your day clinical practice. So that's my hospital, from the Prince Charles Hospital, Brisbane. So before I start, I think I'll give a few seconds for you to read this slide, because I think that's from the PCP Act, and I think it's very relevant to your practice of ultrasound in the Indian scenario. So I'll start with this famous quote by the Swami Vivekananda: "A new idea is the first condemned as ridiculous and dismissed as a trivial until finally it becomes what everybody knows." So as you all know, the journey of echocardiography started in 1956 with the M mode and all the way up to 1997 with the 3D echocardiography. So Dr. Calgon in 1984 in San Francisco started using transesophageal echocardiography as a hemodynamic monitoring, and that's how we started with our journey of echocardiography. So even in the cardiac surgery, in the situations apart from the toe, transthoracic can be possible in the following situations. So even in the case of hypoxia, you can do a bedside transthoracic echocardiography and ultrasound of the lung with the various situations as described in the table. So as you can see, the most of the times, the auscultation by the auscultation is actually been more subjective, and it differs from person to person. So what's the role of transthoracic in anesthesia? You can see it's already been used in emergency medicine, radiology, cardiology, critical care medicine. And if you've already been using transesophageal echocardiography in a cardiac theatre complex, so for the most of the cardiac anesthetists, it is basically cakewalk. It's easy to learn, images are upside down, and got a short learning curve. So actually, this is the platform set up by the New England Journal of Medicine point of care ultrasonography. This is the article actually started and make sure that we started using a point of care ultrasonography in daily clinical practice. And this article actually started a point that this can be actually used by other specialties. So point of care ultrasound can be used by the service provider and then by the treating physician at a point of care at the bedside. So the important part is basically it guides in acute care decision making. So having said that, aim and objectives of point of care is limited. It's done in the point of care, and the whole intention is not to replace the conventional TT, but it's basically help in better informed management decision. So this is another article which came by the ASC in 2013, which talks about the focused cardiac ultrasound. And I think this is probably the important victory landmark so that all other specialties start using it. And you can see that there are three important points which I'm going to talk for next few minutes, because the equipments are available and they started getting transistors, equipments, technology are changing, and it's easily available, cost effective. And the second point is realizing that you can do it. And then I'm going to talk about how to avoid the resistance from other cross specialties. So there are handheld devices are available. So our results are going to get better. You can see there are issues with the quality of equipment, condition investigated, patient habitus, and operator experience. And because of the limitation of color flow Doppler and spectral Doppler modalities in the handheld devices, it can actually make a lot of difference. So in this table, actually I've been described a point of care transthoracic, which has been labeled with different names, like a focus, limited, goal directed, bedside, rapid, and portable. So in this comparison with the handheld devices, you can see that most of these handheld devices have a capability of 2D and color without any advanced Doppler and other hemodynamic monitorings. So handheld devices versus standard devices, you can see in the expert hand, despite the lack of the spectral Doppler modalities, are highly reliable and valuable screening tools for structural heart diseases, even in the abdominal aortic aneurysms. So this is an interesting paper which is done in 2005, where they compare the medical student versus the cardiologist, and you can see the accuracy of medical student is 73% with the cardiologist. So even in the non-cardiologist, you can see that even with the help of the clinical ultrasound, their accuracy has improved. In case of emergency medicine, in the emergency department, they have found that accuracy of diagnosing the pericardial effusion by the emergency physician have gone from 68% to 96%. So about the resistance, most of the, like I was been involved in the instructor as a various workshop and conferences and ultrasound, and people ask how we're going to tackle with this. One of the best things you have to actually convince yourself, your department, your colleagues that this is a complementary to the diagnostic ultrasound. Even for your cardiologist and radiologist, you should be able to tell them that this screen is going to pick up a more referral and not going to actually jeopardize from their normal routine work. And obviously, the important part is you have to actually develop an education and research team along with the help of the cross specialties. And the last, I think the more important thing is you have to hold license, you have to get more qualified. Luckily, Australia New Zealand College have a special guidelines, special documents, which will help you to hold the documents. Even the critical care medicine department, Australia New Zealand, have a guidelines to develop the ultrasound qualifications. And if you're looking for a better qualification, much more qualification with the international, then National Board of Echocardiography got a wide range of examinations and recertification examinations. Then about this ultrasound tsunami, you can see that last probably 15-20 years, you can see that there is a tsunami of ultrasound starting from the heart all the way up to the various regional airways, stomach, and even spine. So a bit of evidence. You can see in the transesophageal echocardiography, in the intraoperative cardiac surgery, there are 10 prospective observational studies, even though there is no randomized controlled trial. Most of the literature is suggesting, though coming from the non-comparative study. So what about the toe in the anesthesia and intensive care? There are 29 observational studies with a level 2B evidence, with a change in the diagnosis and the surgery up to 50%. So what about the transthoracic and anesthesia and critical care? There are about 13 prospective observational studies, 2 randomized controlled trials, with the same change in the diagnosis and surgery up to 50%. So what is change? What you're looking for? Yes, hemodynamic management, post-operative care. But the important thing is we are looking for a change from reactive to proactive. So if the same patients come from the preoperative clinic, let's say somebody coming for a major surgery, so 1 in 5 patients, you can say, means I'm talking about the really serious business, then you can find that 1 in 5 patients is going to have some trouble. So where you're going to have a step-up care in 20% in terms of investigation, monitoring, use of vasopressors, ICU and SDU supports, and step-down care in about 30%. What about the emergency medicine? You can see in emergency medicine, there is a step-up care in 20% and step-down care in about 30%. So these are some of the conditions, as you can read through the chart, there are some of the conditions with the intermediate to advanced type of skills, you can diagnose most of the condition on the bedside. So what about the outcome, particularly in a non-cardiac surgery? So this is a study which has been involved with the neck of femur, which talk about the high-risk populations, which is a retrospective study, but unfortunately it has to be stopped because the cognition is one of the factors which need to be followed up, which was possibly very prominently in this group of patients. So we come up with the ECO-NOP2 study. Essentially, it's the echocardiography done for a fraction of patients before the surgery, and then we divide into 2 groups. So this paper is going to come up in a line and going to be present in the Australian New Zealand College of Anesthetists in coming 6 months. So essentially, the pilot study with a 30 days follow-up, which concluded that this pilot study has established feasibility, calibrated the primary outcome, and shows sufficient group separation favoring the focused cardiac ultrasound. Don't you think it is a great change? Yes, but what about the 50%? If 50% are actually been positive, what about the other 50%? Look at the lung ultrasound publications, which started with 1985, with probably less than 40, and now in 2016, about 150 publications. So what you can diagnose with lung? Pneumothorax, consolidation with the pleural effusion. So yes, this is the blue protocol, which is done in the lung ultrasound in 200 patients in ICU. Shows the similar sensitivity and specificity compared to the CT scan, that is computerized tomography, in a patient with asthma, COPD, pulmonary embolus, pneumothorax, and consolidation. So what about the evidence in the medical ICU? Routine and all admission done with the help of transthoracic and a lung ultrasound. You can see there's a lot of accuracy in diagnosing these lung pathologies with a change in the diagnosis, with a step-up care and a step-down care. So what about the evidence in the after cardiac surgery? So what they found, they can diagnose pleural effusion, pneumothorax, consolidation, and acute pulmonary edema up to 40% of the patients with a step-up care and step-down care in 15% of the patients. So lung ultrasound in the ward, even they found that about accuracy has gone from the almost 34% compared to the clinical and chest X-ray to almost 95% with the help of the clinical ultrasound. So they done a survey in 2012 and 2015, and they found that education awareness has gone from almost 26% to almost 51%. So what about the vascular access? There are multiple randomized control trial and meta-analysis which shows that almost A1 category evidence in all sort of ultrasound vascular access. Pretty easy. You can see the carotid on the left side, IGV on the right side, not rocket science. So what you don't want to see is this, the patient with a big hematoma in the neck and you don't know where are you. What about the NICE guidelines? So NICE guidelines come in 2002 and they compare 500 patients before and after, and they found that complication rate has gone by almost 50%. What about the Cochrane review? Cochrane review says that it increased the overall success rate, decreased the overall complication rate, and not sure in the experience side. So they are not very sure whether if you use a clinical ultrasound with a clinical ultrasound and compare them with the blind with experience. So that's probably the more area to tackle or to search for. So what about the regional anesthesia? There are about 2 meta-analysis, 23 randomized control trial. But what it says, it's a more efficient, less serious complications, better anesthesia. It's probably equivocal. But however, the important thing is because of the introduction of the ultrasound, they found that there is a rapid advancement of the acute and chronic pain specialties. So I believe it's just a tip of iceberg. It's going to cross over and spread all specialties, even in interns, residents, paramedics, pre-hospital settings. So this is how actually I feel they've been set up as expertise pyramid. If you can see on the bottom, it's basically you can start using an ultrasound guided examination, which is the starting point, which is based on the pattern recognitions. And if you see on the top, which has been labeled as a star, then this has been actually probably the teachers or the experts. So how are we going to go there? So I think yes, particularly from the Indian perspective, you can argue that I'm in private practice, I don't have time, how am I going to, but yes, there are courses are available, education is available, resources are available. And about this apprenticeship model, probably it's very difficult. It's very difficult to help and visit and go and see the experts and work with him in a busy private practice. But having said that, probably that's the way it should be. So what's next? Avinash has done probably, I think, pretty good job. So I'm going to skip these few slides about the perioperative situations. Airway, yes, airway is possible. You have different types of article. It's basically, I believe, I started doing this airway for last 2 years. It's pretty easy. You can do it in and out every day, even when the patient is anesthetized. It's based on the pattern recognitions. It's not a difficult task. So yes, if you're doing a thoracic anesthesia, double lumen tube and ultrasound. So absence of lung sliding and presence of lung pulse on the side of the surgery and the lung sliding sign seen on the opposite side is possibly the way to diagnose the lung isolations. It can be done in a routine procedure. You can do a routine screening, but it's a subjective. You need a practice, you need a number. So what's the limitation? You cannot rule out the advancement of the tube during the procedure when you position the patients. And if you're looking for airtight situations, anyway, you need a bronchoscopy. So yes, the next step is the diaphragm. Actually, you can actually do in anesthetics, ICU, you can find out the diaphragmatic dysfunctions by means of the diaphragmatic movements in the inspiration, expirations. You can find out the thickness and help you in diagnosis of diaphragmatic dysfunction. And the last is the gastric ultrasound. So these are 4 different diagrams. One on the left top is actually showing L for liver. That's a liver with the antrum and the aorta on the bottom. So it's easy. It's a totally collapsible stomach. One on the right side top is a full of fluid. And on the left bottom, you can see it's stomach with a solid food. So what's the advantage? I think I covered most of this. The important part is it's a feasible, possible to learn, easy to do, provided we got access to the chest. And the most important thing is basically you don't have to depend on anybody. You can get the machine, start doing it on your own, and the number is the important point. So what's the disadvantage? If you see all the list of the disadvantage, the most important thing is to keeping your skills. You have to keep doing it. Otherwise, it's going to be difficult. The most important part I feel when I'm being called for the emergency situation is the access to the chest. And the other last but important part is the wrong interpretation in the diagnosis. So I think it's a rise of machines. You can talk this in terms of ultrasound as a disruptive medicine. It's been assisted for a clinical examination, for procedures, and an important part of the medical education for the last 3 to 4 years. So should we perform echocardiography in all our patients? The short answer is no, because probably they haven't found enough evidence or no benefit. So obviously it's going to delay few of the, I'm going to take a couple of more minutes and wind up. So these are the 4 conditions: cardiovascular disease who need cardiovascular inotropic and mechanical support, major vascular surgery, surgeries with anticipated major hemodynamic and fluid changes, and conventional anesthetic monitoring does not answer your clinical situations. So what we are looking for, everything under one roof. So to summarize, there are improvement in educations, the technology, the transducers are getting smaller and smaller, easily available with the basic affordable equipments. So I'm looking like clinical ultrasound or can be a new standard in the monitoring in anesthetic practice. Thank you.